Ji, good afternoon, class. Sarah Rooj, how are you? Have you completed the cardiovascular system assessment? इसमें आपने बुक्स को कंसल्ट किया?
चीजें पड़ी हुई है ना आपने ऐसे रखी अभी भी मैं उनको कह रही हूँ नसरीन का पीरियड्स का इमरजेंसी का पैथो का सारा कंटेंट पड़ा हुआ क्या मैं आजाद साफ करने के लिए रह गई नहीं वो उनको देखो वही ना इनके नोटिस बोर्ड में ठीक करो और इनकी तुम्हारे में सर्च करो
मैम मेरा अभी लेक्चर है ये कैसे मैनेज कर
और उनको बड़ा बुरा लगता है
जी ये नहीं बताया आपको, इसको लग रहा है। हाँ जी क्लास, हाउ आर यू? आप मुझे सुन रहे हैं? अभी तक 2 स्टूडेंट सिर्फ ऑनलाइन है और 11 की आपकी क्लास है। दिस इज़ रियली नॉन प्रोफेशनल एटीट्यूड कि आप लोग सब जो है ना टाइम पे ऑनलाइन ही होते हैं। अगर मैं देखूँ इस टाइम तो शहर अरूज सिर्फ ऑनलाइन है।
And then I'm going to do category, which means that you press the nail, and here you should place your ball. Release the nail, and you come back to keep. How many seconds it takes for you to go and plant you. Back to you. First is less than 3 seconds. I'm also going to have those fingers together like this. And you can see she has there should be a space there too. So, press together, press together. And so you can start either down here or up here. I like to start with the big toe and so, and I just start feeling it moving up.
Thank you, Mr. Jackson. I'd now like to examine your heart, please. Can I ask you to undress to your waist and please take your shoes and socks off? Thank you. So please. As Mr. Jackson is getting onto the couch, I'm looking for any signs of discomfort. See movement of the hands and back. I'm checking for any obvious abnormalities such as discomfort at rest, tachypnea, pallor, cyanosis. Thank you, Mr. Jackson. I'd now like to examine your heart, please. Could I ask you to undress to your waist and please take your shoes and socks off? Thank you. Thank you, Mr. Jackson. I'd now like to examine your heart, please. Could I ask you to undress to your waist and please take your shoes and socks off? Thank you. Thanks, sir. Please come to the couch. As Mr. Jackson is getting onto the couch, I'm looking for any signs of discomfort. I'm looking to see any ease of movement and whether he's breathless. I then stand back and have a look at the patient as a whole. I'm checking for any obvious abnormalities such as discomfort at rest, tachypnea, pallor, cyanosis, scars, or items of note around the bedside, such as intravenous infusions that might be present on a ward. Look how Mr. Jackson is positioned. He's reclined at 45 degrees, his hands are by his side, and his chest is fully exposed. For female patients, after initial inspection, it is usually customary to cover their chest until their precordium is examined.
For female patients, after initial
Could I have a
inspection,
look at your
it
hands?
is usually customary to cover their chest
Thank you.
until their precordium is
In the
examined.
hands, I'm looking for signs of clubbing, peripheral cyanosis, cigarette staining, or splinter hemorrhages. This should only take a very short period of time before moving on to examine the radial
Peripheral
pulse.
cyanosis, cigarette staining, or splinter hemorrhages.
I'd like to feel your pulse.
This should
now,
only
please.
take a very short period of time before moving on to examine the radial pulse.
When examining the radial pulse, it is important to identify both the rate and the rhythm, and also allow at least 15 seconds to provide a good estimate of the patient's pulse rate.
Important to identify both the rate and rhythm, and also allow at least 15 seconds to provide a good estimate of the patient's pulse rate.
Thank you. Can you have both your hands? By examining both the radial pulses, I'm able to identify any evidence of radial delay. Thank you.
By examining both the radial pulses,
If I suspect
I'm able to identify
aortic regurgitation, then I examine for a collapsing pulse. Initially examining the radial pulse by the patient's side, after warning them, I'll briskly raise his arm above his head. So I'm just going to raise your arm above
initially
your head.
examining the radial pulse by the patient's side. After warning them, I'll briskly raise his
Thank you.
above his head. So I'm just going to
Next, I examine for the brachial pulses. May I have your arm, please, sir? I'm just going to examine for the pulse. Thank you. This gives further insight
Next, I
into the
examine
volume
the
and the
brachial
character
pulses.
of the pulse. The brachial pulse is located medial to the biceps at the
This gives
cubital
further
fossa.
insight into the volume
Thank
and
you.
the character.
I'd just like to examine your other arm, please.
The brachial
Thank you.
pulse is located medial to the biceps at the cubital fossa. Just like to examine your other arm, please.
I'd just like to measure your blood pressure in your right arm, please. It is important to examine the patient's blood pressure at this point.
I'd just like to measure your blood
On the
pressure.
first occasion, the blood pressure should be measured in both the right and left arm. And of course, the blood pressure should be measured in standard if the patient is at risk of postural hypotension.
Blood pressure should be measured in both the right and left. And of course, the blood pressure should be measured standard if the patient is at risk of postural hypotension.
Examination of the face may reveal a malar flush, which is characteristic of mitral valve disease. This is known as a mitral facies. I'd like to examine your face.
Examination of the face may reveal a malar flush, which is
Now, I should take your glasses
mitral
off.
valve disease. This is known as a mitral
Please look
facies.
up for me.
I'd like to examine your face.
Examination of the conjunctiva may reveal evidence of anemia. The iris may show an arcus, and around the eyes there may be evidence of xanthoplasm.
Examination of the conjunctiva.
Can you
may
please
reveal
put your
evidence of
glasses back
anemia.
on?
The iris may show an arcus,
Can I ask you to open your mouth
and around the eyes there may be evidence of xanthoplasm.
and stick out your tongue, please?
Can you please put your glasses on?
Thank you. It is essential to examine the mouth in a patient whose poor dentition can be a source of bacterial endocarditis. Cyanosis will be evident from blue discoloration of the
It is
mucosa.
essential to examine the mouth in a patient whose poor dentition can be a source of bacterial endocarditis. Cyanosis
I'd
will
like
be
to examine the
evident
vein in
from
your
blue
neck, please.
discoloration.
Can you rest your head back and look to the left? Lovely, thank you. The internal jugular vein arises between the two heads of the sternocleidomastoid, the medial and the lateral heads.
Thank you.
If the JVP
The
is
internal
elevated,
jugular vein arises
then it can be
between
measured as
two
the
heads
vertical
of
height
the
from the
sternocleidomastoid,
sternal angle.
the medial and the lateral.
It's normally equal to or
If
less
the
than 3
JVP is
centimeters.
elevated, then it can be measured as
Eliciting the
vertical height.
hepatojugular reflux
from the sternal
is
angle.
normally unnecessary.
It's normally equal to or less than 3 centimeters.
Both of the carotid pulses should be
Eliciting
palpated,
hepatojugular
but be
reflux
sure to only feel one
is
at a
normally
time
unnecessary.
to prevent the patient feeling faint. Please relax your head back. I'd just like to
Both
feel
of
the
the
pulses.
carotid pulses should be palpated, but be sure to only feel one at a time to prevent the patient feeling faint. Lean back your head back. I'd just like to feel the pulse on you.
The examination of the precordium is like any other examination, and thus should include inspection, palpation, and auscultation. Noting for the cardiac examination,
The examination
percussion of the heart is not
like any other
required.
examination.
At this
Thus should
point,
include
you must
inspection,
ensure that the chest is fully
palpation,
exposed.
and auscultation.
I'd just like to look at the
Noting
front
for
of your
the
chest,
cardiac
please.
examination.
Can I ask you to put
Percussion
your
of
arms
the
by
heart
the
is not
side?
required.
Thank you.
At this point,
Excuse me.
you must ensure that the chest is fully exposed.
It is important to inspect
Just
the
like
previous
the front
operative
of your
scars
chest, please.
for visible
I should
apical
put your arms by the
pulsation
side.
and listen for an audible click of prosthetic heart valves.
It is important to inspect the previous operative scars for visible apical pulsation.
The
and
apex is
listen
normally
for an
located in
audible
the
click
fifth intercostal
of
space,
prosthetic heart
left
valves.
midclavicular line, unless displaced by enlargement. As well as any displacement, the
The
character of the
apex is
apex
normally
is
located in
noted.
the fifth intercostal space.
If the apex beat is hard
left
to locate,
midclavicular line,
you can ask the
unless
patient to
displaced
roll
by
to their left,
enlargement.
but you will no
As
longer
well as
be
any
able to comment
displacement,
on the position of the
character of the
apex.
apex beat is noted.
I'm now going to feel for your heart.
The apex beat is hard to
Excuse me.
locate. You can ask the patient to roll to their left, but you will no longer be able to comment on the position of the apex.
I'll just check
your
its
heart.
location.
Excuse me.
Palpation with the base of my hand, just
Now
left
just
of the
check its
sternum,
location.
might identify a parasternal heave, which would indicate right ventricular hypertrophy.
Palpation with the base of my hand,
Palpating over the
just
valvular
left of the
areas,
sternum,
might
might
identify the
identify
presence of
parasternal
fluid.
heave, which would indicate right ventricular hypertrophy.
Auscultation of the
Palpating
heart
over the
should start
valvular
at the
area.
apex. It is
Might
important to
identify the
identify the
presence of-
first and second heart sounds, then the additional sounds, S3 or S4.
Auscultation of
And
the
then
heart
any
should
murmurs.
start at the apex.
There are a number
It
of
is
strategies
important
for
to identify
auscultating
the
the
first
heart,
and second heart
and is
sounds,
likely you'll develop your
then
own
the
way of doing
additional
this.
sounds, S3,
However, it is
S4,
orthodox to
and
start
then
at the
any
apex
murmurs.
and proceed towards
There are
the
a
base
number
of
of
the heart.
strategies for auscultating the heart.
If you need to time
and
the
is
murmurs,
likely you'll
then
develop your
palpate
own
the
way of
carotid
doing
artery.
this.
A
However,
pulsation
it's orthodox to
indicates
start
system.
at the apex and
I'd
proceed
now like to
towards
listen
the
to your
base
heart,
of the
please.
heart. If you need to time the murmurs, then palpate
Excuse
the
me.
carotid artery. A
At
pulsation
first, using the
indicates
diaphragm, I listen over the apex.
Now let's listen to your heart.
First, second, and any additional heart sounds. This area is ideal for listening for murmurs of
First,
mitral valve
using the
disease.
diaphragm, I listen to the
I then proceed to listen at the axilla.
first, second, and any additional heart sounds.
This
This
is
area
an
is
ideal
ideal
for
for listening to
radiation
murmurs
of
of mitral
mitral
valve disease.
regurgitation.
Then proceed to listen.
I then, by using the bell, listen over the
This is
apex
another
again.
area for listening for
I'm
radiation.
listening
of
for the
mitral
low
regurgitation.
pitched murmur of mitral stenosis.
And then,
This
by
murmur can
using
be
the bell,
accentuated by asking the
listen
patient
over the apex
to move to
again.
their left.
And listening for
Move to
the
your left,
low-pitched murmur of mitral stenosis.
Thank you.
This murmur can be accentuated by asking the patient
I then proceed to the
to their left.
examination again by listening with the diaphragm, the lower left sternal edge, and the second intercostal
I then
space
proceed
on
to
the
the
left,
examination
pulmonary
again by
area,
listening to the diaphragm. The lower
and
left
the
sternal
second
edge,
intercostal space on the right, the aortic area.
the second intercostal space on the left,
Murmurs of aortic stenosis often radiate to the base
and the second
of the
intercostal
neck,
space on the
sometimes
right.
best heard in this location.
Murmurs
It's
of
important
aortic stenosis
to
to
listen
radiate to the
at
base
carotid breweries.
of the neck, and sometimes best
Listen
heard
them
in
in
this
turn in the left and then the right by asking the patient to hold their breath.
It's important
Can you hold your
to
breath,
listen
please?
to the carotid breweries.
Thank you.
Listen in turn to the left and the right by asking the patient to hold their breath.
Thank you. And breathe normally. I often hold my breath at the same time as the patient as a way of reminding me to ask the patient to breathe again. Can I ask you to sit forward, please?
I often hold my breath
To complete my examination of the precordium, I listen at the left lower sternal edge for the early diastolic murmur of aortic cogitation. This is best heard in
my
the
examination
expiration.
of the cordium. I
Just
listen
take a
at the
brief
left lower
breath in.
sternal edge. The
Breathe
early
out.
diastolic murmur of aortic cogitation.
Hold your breath,
This
please.
is best heard in the expiration. You have to take a brief
Thank you.
breath in.
Breathe again.
Breathe out.
While the patient remains in this position,
Hold your breath.
it is possible to listen to the lung bases for any evidence of pulmonary edema.
While the patient remains in this
Please remember, all left-sided heart murmurs
possible
are
to listen to
accentuated
lung
if a
bases
patient holds their
for
breath
any
in
evidence.
expiration,
of
and right-sided heart murmurs are accentuated if a patient
Please
holds their
remember,
breath.
all left-sided heart murmurs are accentuated if a patient holds their breath in expiration, and right-sided heart murmurs are accentuated.
Part of the cardiovascular examination includes examination of the rest of the peripheral pulses. It is important to examine for both the dorsalis pedis and the posterior tibial pulses in all
After the
patients.
cardiovascular examination,
I'd like to examine the pulses
examination
in your
of
feet,
left
please.
peripheral pulses.
Firstly, I
important
feel
to
for the
examine
dorsalis
both
pedis
dorsalis
pulses,
and the posterior tibial pulses of all patients. I'd like to
and
examine
then
the pulses
the posterior tibial pulses.
Firstly, I feel the dorsalis pedis pulses, and then the posterior tibial pulses.
Finally, both ankles should be inspected for peripheral edema. Sometimes edema can be tender, so warn the patient before applying any pressure. I'm now going to press
Finally,
behind your ankles.
both ankles should be inspected for peripheral edema.
I
Sometimes
usually press for
edema
about
can be
5
tender,
seconds
so warn
behind
the
the medial
patient before applying
malleolus,
any pressure. Now I'm going to press behind your ankles.
and then feel if any indentation remains afterwards.
Usually press for about 5 seconds.
If pitting
behind the
edema is
malleolus,
present, identify the extent of the edema up the limbs.
and then feel
If a patient is
any
bedbound,
indentation remains
look at the
afterwards.
lowest point of gravity, the sacrum.
If pitting edema is present, identify the extent of the edema up the limbs. If a
In
patient is
right heart
bedbound,
failure,
look
there
at the
may be an
lowest point of
indication for
gravity,
examination of the
sacrum.
abdomen for evidence of ascites or hepatosplenomegaly. In addition, patients with vascular
In
disease
right heart
require a
failure,
full
there
vascular
may be an
examination,
indication for
including
examination
identification of any abdominal
evidence
aortic
of
aneurysm.
ascites or hepatosplenomegaly.
Those patients with a history of uncontrolled
In addition,
hypertension,
patients with
occasional
vascular
renal
disease
bruise can
require
be
a full
heard in
vascular
auscultation,
examination,
indicating
including
renal
identification
vascular
of any
disease.
abdominal aortic aneurysm.
Examination of the eyes
Those
by
patients with a
fundoscopy
history
is
of
desirable in those
hypertension,
patients with a history of
occasionally renal
diabetes,
bruise can be heard in
hypertension,
auscultation,
or endocarditis.
indicating renal vascular disease.
Bedside investigations would
Examination of
include
the eyes by
recording temperature
fundoscopy is
and
desirable in
urine
those
analysis.
patients with a history of diabetes, hypertension, or endocarditis. Bedside investigations include temperature and urine analysis.
Good overview. These include inspection, looking at the patient. Where is the pain? When does it occur? Descriptions such as shortness of breath, sweating, nausea relieved by sitting up. Does it occur when they bend over or when they cough? Swelling or edema. When is it worse, morning or evening? Does it improve with elevation? Ask the patient about their history and risk factors, such as personal or family history of heart disease, including hypertension, type 2 diabetes, physical activity, smoking status, diet, and alcohol or drug use. Thrombophlebitis, bleeding disorders, or easy breathing.
Welcome
Gather
to this video
information
on
regarding
cardiovascular assessment. We will be looking at the various aspects of assessment that are necessary to get a good overview of a patient's cardiac condition.
During activity.
It's important to look at the subjective data, or the patient's point of view, and the objective data, the aspects of a patient that are measurable
patient
with
had any skin
examination
changes?
and tests.
Such as redness or pallor.
These include
Cold
inspection,
skin,
looking
visible
at the
veins
patient,
or lower leg.
palpation, feeling the patient,
Elderly
and
patients may complain of
auscultation,
chest pain,
listening
or
to
they
the
may have
patient's
less
heart.
obvious complaints.
Subjective
related to
data allows you to gather
myocardial
the
infarction,
patient's common
such as
concerning
dyspnea,
symptoms, including
diaphoresis, nausea and vomiting,
chest pain.
or syncope.
Where is the pain? When does it
Ask
occur?
the older patient about
Describe the
dizziness,
intensity,
syncope,
type,
confusion,
duration.
or orthostatic hypotension.
Does it radiate?
These
Does it come
symptoms
with
may be
or without
related to heart
exertion?
or circulatory changes
Any associated
and
symptoms,
indicate a
such
reduced
as
blood
shortness of
supply
breath,
to the brain.
sweating, nausea,
It is important
palpitations,
to gather
or
accurate
anxiety.
objective data,
Does anything
including vital
alleviate or
signs and
aggravate the
height
pain?
and weight,
Does
which
the
will
patient
provide
have
valuable
palpitations?
information about
Ask if they have a
cardiovascular
sensation
function.
of racing, skipping,
Height and
fluttering,
weight trends
pounding, or
assess
stopping
fluid
of
and
the heart.
nutritional status.
Does the patient have
Abrupt
shortness of
weight
breath
change will
or
indicate
dyspnea,
fluid gain or
difficulty
loss.
breathing?
Weight
Does
loss
it occur
over
with
months
lying
or
down
years
and
may
relief by
indicate
sitting up?
advancing cardiovascular
Does it
disease
occur
and
when
be
they
a
bend
sign
over
of
or
poor
when they
nutrition
cough?
and muscle wasting.
Swelling or edema?
Weight should
When
be
is it
measured
worse,
first thing in
morning
the
or
morning
evening?
after urination,
Does it
but
improve
before
with
dressing
elevation?
or eating. When checking
Ask the
vital
patient
signs,
about their
take the
history
blood pressure,
and risk
pulse,
factors,
and
such as
respiration near
personal
the
or
same
family
time.
history of heart
Be
disease,
sure to use the
including
appropriate blood pressure
hypertension,
cuff size.
type 2
If the
diabetes,
cuff is too
physical
large,
activity,
readings will be artificially
smoking
low.
status,
And
diet,
if the
and
cuff is
alcohol
too
or
small,
drug use.
the readings will be artificially high.
Thrombophlebitis, bleeding
If you
disorders,
obtain an
or
abnormal
easy
vital
bruising.
sign, recheck it to make sure
Gather
you're getting an
information
accurate
regarding
reading.
the patient's usual activity, such as
Aspects of
prolonged
objective
standing,
data
walking,
include
or sitting.
inspection.
Does the
Begin your
patient
inspection
experience
when you
pain
first
in the
encounter
legs
the
during
patient,
activity,
looking at their
numbness or
general
tingling,
appearance. Are they thin
aching
or
or
obese?
cramping,
What
swelling
is their
in the
level
legs
of
or feet?
alertness? Anxious, drowsy, or lethargic?
Has the patient had any skin changes,
What about
such as
skin
redness
color,
or pallor,
turgor,
cold
texture,
skin,
and temperature?
visible veins, or lower
Are
leg
mucous
ulcers?
membranes pale?
Elderly
Do fingers
patients
have
may
blood
complain of
vessel
chest pain,
sinus?
or they may have less obvious complaints
Observe for
related to a
pulsations or
myocardial
retractions
infarction,
and symmetry of
such as
movement to the
dyspnea,
chest wall while the patient is
diaphoresis,
sitting or
nausea and
lying
vomiting, or syncope.
flat. Examine the
Ask
extremities,
the older patient
looking
about
for
the
arterial
dizziness,
or venous
syncope,
disorders,
confusion, or
noting
orthostatic
symmetry,
hypotension.
edema,
These
leaking,
symptoms may be
lesions,
related to heart or
scars, and skin
circulatory
color.
changes and
Check
indicate
for
a reduced
jugular
blood
vein
supply to the
distension,
brain.
or JVD, by positioning the
It is
patient on
important
their
to
back,
gather accurate
elevating the
objective
head of the
data,
bed 45
including
degrees,
vital signs
and
and
turning the
height and weight,
patient's head slightly
which will
away
provide
from you.
valuable information
Look
about
for a pulsation
cardiovascular
in the neck that
function.
occurs in several waves with
Height
each
and weight
cardiac
trends
cycle.
assess fluid and
If you see a
nutritional status.
pulsation and are not sure if
Abrupt
it's
weight
JVD
change will
or the
indicate
carotid
fluid
pulse,
gain or loss.
palpate the radial
Weight
pulse
loss
while
over
watching the
months
neck,
or years
and
may
if the
indicate
single pulsation in the
advancing
neck
cardiovascular
coordinates with the
disease
radial
and be a
pulse,
sign of poor
you are seeing
nutrition
the
and
carotid
muscle
pulse.
wasting.
Normally, the jugular
Weight should be
veins are
measured
not
first thing in the
distended when
morning
head is
after
elevated at
urination, but
45
before
degrees.
dressing or eating. When
Palpation
checking
is
vital
sometimes
signs, take the
overlooked,
blood
but
pressure,
still an
pulse,
important
and
aspect of the
respirations near the same
cardiovascular
time.
assessment.
Be sure to
Palpate the
use the
apical
appropriate
impulse,
blood pressure
noting the
cuff
size,
size.
location,
If the cuff is
intensity,
too large,
amplitude,
readings will
and
be
duration.
artificially low.
It should be a gentle
And if the
pulsation
cuff
that
is too
coincides
small,
with the
the
carotid
readings will be
pulse.
artificially high.
Palpate the patient's
If
extremities
you obtain
to
an
assess
abnormal
skin
vital
temperature,
sign,
texture,
recheck it to make sure
turgor,
you're
and
getting an
edema.
accurate reading.
Edema is measured on a 4-point scale.
Aspects of objective
From 1
data
plus,
include
the finger leaves a
inspection.
slight indentation.
Begin your
To a
inspection when
4
you
plus,
first
the
encounter the
finger
patient,
leaves a deep
looking
imprint
at
that
their
returns
general
to normal very
appearance.
slowly.
Are they thin or obese?
Check
What
capillary
is their
refill
level
by
of
pressing the
alertness?
nail beds on
Anxious,
fingers and
drowsy,
toes,
or
and refill
lethargic?
time should be 3 seconds or
What
less.
about skin color,
Use the
turgor,
pads of your
texture,
index and
and
middle
temperature?
fingers to palpate all pulses,
Are mucous membranes
including
pale?
temporal,
Do
carotid,
fingers have
brachial,
clubbing or
radial,
cyanosis?
femoral, popliteal,
Observe for
posterior
pulsations
tibial,
or
and
retractions
dorsalis
and
pedis.
symmetry of movement of
All
the chest
pulses should
wall
be equal
while
in
the
strength
patient
and
is sitting
regular
or
in
lying
rhythm.
flat.
Auscultation of the
Examine the
heart can be done
extremities,
with the patient
looking
in
for
3
arterial
positions:
or venous
sitting up,
disorders,
lying on the
noting
left side,
symmetry,
and lying on the
edema,
back with the
weeping,
head of the bed
lesions,
elevated 30 to
scars, and
45
skin color.
degrees. Use a
Check
good
for
quality
jugular vein
stethoscope with
distension,
snug
or
fitting
JVD, by
earpieces.
positioning the patient
Use
on
the
their back,
diaphragm to hear
elevating the
high-pitched
head of the
sounds.
bed 45
Use the
degrees,
bell held
and
lightly
turning the
against
patient's
skin
head
to hear
slightly away
low-pitched
from you.
sounds.
Look for a
A
pulsation
quiet
in the neck
environment
that
is
occurs in
essential to
several
hear heart
waves with
sounds
each
and
cardiac
accurately
cycle.
evaluate.
If
So
you see
turning
a
off the
pulsation
TV
and
or
are
other
not sure
background
if it's
noises may be
JVD or the
necessary.
carotid pulse, palpate the radial pulse
Auscultation
while
is best
watching the neck,
performed directly
and
on
if a
bare
single
skin,
pulsation
as
in the neck
clothing can
coordinates
mimic
with the
abnormal
radial
sounds.
pulse, you are
Hair
seeing
on
the
the
carotid
chest can
pulse.
also cause friction under
Normally, the
stethoscope.
jugular veins are
This
not
can be
distended
minimized
when the
by
head is
lightly wetting the
elevated
hair
at
before
45 degrees.
auscultation. As you listen to the
Palpation is
heart over
sometimes
the entire
overlooked, but
precordium
still
or
an important
anterior chest
aspect
wall,
of the cardiovascular
use a zigzag
assessment.
pattern, starting at
Palpate
the
the
base of the
apical
heart and
impulse,
working
noting the
downward
size,
toward the apex.
location, intensity, amplitude,
Normal
and
heart
duration.
sounds,
It should be
S1
a
and
gentle
S2,
pulsation that
are caused by
coincides with the
events in the
carotid
cardiac
pulse.
cycle. As
Palpate the
blood flows
patient's
from the
extremities
atria
to
to the
assess skin
ventricles, it
temperature,
goes through the
texture,
tricuspid and
turgor,
bicuspid
and
valves.
edema.
These valves
Edema
then
is
snap
measured
shut,
on a
making the
4-point
first
scale,
heart sound,
from
or
1
S1.
plus if the finger
This is the
leaves a
loved
slight
and loved up.
indentation, to a 4 plus
As
if the
these two
finger
valves
leaves a
snap
deep
shut,
imprint
the
that
pulmonary
returns
and
to normal
aortic
very
valves
slowly.
just open. This is the
Check
beginning
capillary
of systole,
refill by
or
pressing the
contraction
nail
of the
beds on
ventricle.
fingers and toes, and
As the
refill time
ventricles
should be 3
contract,
seconds
blood
or
is
less.
pumped through the pulmonary valve,
Use the pads
leading
of your
to the
index
lungs,
and middle
and the
fingers to
aortic
palpate
valve,
all
leading to
pulses,
the aorta and
including
rest of the body.
temporal, carotid,
These valves
brachial,
then snap
radial,
shut,
femoral,
making the second heart
popliteal,
sound,
posterior
S2,
tibial,
or dub
and
in
dorsalis
love dub.
pedis.
This is
All
the end of
pulses should be
systole
equal
and
in
the
strength
beginning
and
of
regular in
diastole.
rhythm.
When listening
Auscultation of
over
the
the
heart should be
precordium,
done
there
with
are
the
5
patient in 3
precordial
positions:
landmarks where you can
sitting
best
up,
hear sounds
lying
from
on the
each
left
heart.
side, and lying on the
The
back
sites of
with the head of the
auscultation
bed
are
elevated
actually
30
not
to
at the
45
exact
degrees.
anatomic site, but the
Use a good
stethoscope is
quality
positioned
stethoscope with
downstream
snug
from the
fitting
flow of blood
earpieces.
through the valves.
Use the diaphragm to hear
Use the
high-pitched
diaphragm of
sounds.
the stethoscope,
Use the bell,
switching
held
to the
lightly
bell
against
to
the
hear
skin,
lower
to
pitch
hear
sounds.
low-pitched sounds.
The aortic valve
A
area
quiet
is on the right
environment
side
is
of the
essential
second
to hear heart
intercostal
sounds
space.
and accurately
The
evaluate.
next 3 listening
So
points
turning off
lie
the
along the
TV or
left
other
external
background
border.
noises may be
The
necessary.
pulmonic valve area is at the left base of the heart,
Auscultation is best performed
located in the
directly on
second
bare
intercostal
skin,
space.
as clothing can
Erb's
mimic
point
abnormal
is at the
sounds.
left third intercostal
Hair on the
space,
chest can
lying
also
halfway
cause
between
friction
the
under the
base and the
stethoscope.
apex.
This can be
The
minimized by
tricuspid valve
lightly wetting
area
the
is
hair
at the
before
left fourth
auscultation.
intercostal space.
As
And
you
the
listen
final
to the
listening
heart over the
area is
entire
at the apex,
precordium or anterior
normally at
chest
the
wall,
left fifth
use a
intercostal
zigzag
space
pattern,
at the mid
starting at the
ventricular
base of the heart
called
and
the
working
mitral
downward
valve area.
toward the apex.
You can remember these locations
Normal heart
using the
sounds,
mnemonics
S1 and
A,
S2,
E,
are caused
T,
by
M.
events in the
All
cardiac cycle.
people enjoy time
As
magazine.
blood flows from the atria to the ventricles,
As you
it goes
listen
through
to
the
each of these
tricuspid
listening
and
points,
bicuspid
use
valves.
the diaphragm
These
and
valves
enter
then snap
stethoscope
shut,
from one
making the
point to
first
next,
heart sound,
so
or
you can track
S1.
the sounds
This is
and
the loved
concentrate
and
on
loved up.
identifying S1 and S2.
As these two
To
valves snap shut,
differentiate
the
S1
pulmonary
and
and
S2,
aortic valves just
concentrate on the
opened.
rhythm.
This is the
Normally,
beginning of
systole
systole,
is
or
shorter
contraction
than
of the
diastole,
ventricles.
so there is a longer
As
pause
the
after
ventricles
S2.
contract, blood is pumped through
S2
the
is also
pulmonary valve,
louder at the base,
leading to
while
the
S1
lungs,
is
and
louder
the
at the
aortic
apex.
valve, leading to the aorta
S1
and
also
rest of the body.
coincides with the carotid pulse.
These valves then snap shut,
also listen
making the
for
second
abnormal
heart sound,
in
S2,
patients with
or dub
congestive heart
in low
failure.
dub.
You may hear an
This is the
S3
end of
following
systole
S2.
and the beginning of
An S4
diastole.
sound is associated with
When listening
hypertension,
over the precordium,
coronary
there are
artery
5
disease,
precordial
and
landmarks
often a
where you can
myocardial
best hear
infarction.
sounds from each heart valve.
S3 and S4
The
are
sites of
low pitched
auscultation
and
are
better heard
actually
using
not
the
at the
bell
exact
of the
anatomic
stethoscope.
site, but the
After
stethoscope
listening
is
to all
positioned
points with the
downstream from
diaphragm,
the flow of
use
blood
the bell
through the
with very
valves.
light pressure to listen
Use
over
the
the 5
diaphragm of
areas
the
that you
stethoscope,
feel.
switching
Blood
to the
should be
bell to
flowing
hear lower
smoothly
pitch
over the
sounds.
valve. However,
The
if
aortic
a
valve
valve
area
is
is on the
stenotic
right side of the
or it
second
doesn't open
intercostal
widely,
space.
blood flow will be
The next
turbulent,
3 listening
causing
points
a
lie along
swishing
the
or
left
whooshing
sternal
sound.
border.
This is a murmur.
The pulmonic valve
A murmur
area
can
is at
also
the
be
left
caused
base
by
of
a
the
valve
heart,
that is
located in the
regurgitated
second
or does not
intercostal
close
space.
tightly.
Erb's point
Murmurs
is
are
at the
graded
left third
according to their
intercostal
loudness
space,
from grade
lying
1
halfway
to grade
between the
6.
base and the apex.
If you hear a
The
high-pitched,
tricuspid
scratchy
valve
sound
area is
similar
at the
to
left
sandpaper
fourth
rubbing
intercostal
together,
space,
it is likely
and
a
the final
pericardial
listening
friction
area
rub,
is at the apex,
in which the
normally
pericardium,
at the
the
left
membrane
fifth
surrounding the
intercostal
heart,
space
becomes
at the
inflamed.
midclavicular line,
Friction
called the
rubs
mitral
can be
valve
heard
area.
during systole and
You can remember
diastole,
these
and are
locations
generally
using
loudest
mnemonics
at the
A,
apex.
C, E, T, M.
Listening
All
to heart
people
sounds
enjoy
gives
time
concentration to
magazines.
heart. If you're having
As
difficulty
you
hearing
listen
heart
to each
sounds,
of these
ask the
listening
patient
points,
to
use
use
the
position
diaphragm
to bring
and
his
inch
heart
your
closer to
stethoscope
the
from
chest
one
Hello?
wall.
point to the next, so you
Be
can
sure
track
to
the
reduce
sounds
background
and
Hello?
noises
concentrate
and
on
place your
identifying
stethoscope
S1 and
directly on the
S2.
chest wall.
To
Don't
differentiate
Hello?
hesitate
S1
to
and
make
S2,
adjustments as needed.
concentrate on
So
the
your
rhythm.
findings from this crucial
Normally,
assessment
systole
are
is
as
shorter
accurate
than
as possible.
diastole, so there is a longer
Thank you
pause
for
after
watching this
S2.
video tutorial on
S2 is also
cardiovascular
louder
assessment.
at the base,
For more
while
information,
S1 is
be sure to
louder at
check
the
out our other
apex.
videos and follow us on
S1
social
also
media.
coincides with the carotid pulse. Also listen for abnormal
Welcome to
heart
this
sounds.
video on
In patients
cardiovascular
with congestive
assessment.
heart failure,
We will be
you may
looking
hear
at
an
the various
S3
aspects
following
of assessment
S2.
that are necessary
An
to get a
S4
good
sound is
overview of a
associated
patient's
with
cardiac
hypertension,
condition.
coronary artery
It's important
disease,
to
and
look at the
often a
subjective
myocardial
data for the
infarction.
patient's point of view
S3 and
and the
S4 are
objective
low-pitched
data,
and better
the
heard
aspects of
using
the
the bell
patient
of
that
the
are measurable
stethoscope.
with examination
After
and
listening
testing.
to all points with the
These
diaphragm,
include
use the
inspection,
bell with very
looking at
light
the
pressure
patient,
to listen over the 5
palpation,
areas of
feeling the
interest.
patient,
Blood
and
should be flowing
auscultation,
smoothly over the
listening to the
valves.
patient's heart.
However, if a valve is
Subjective
stenotic
data allows you to
or
gather the
doesn't
patient's
open widely,
common or concerning
blood flow will be
symptoms,
turbulent,
including
causing a swishing or
chest
whooshing
pain.
sound.
Where
This
is
is a
the
murmur.
pain? When does it
A
occur?
murmur can also be
Describe
caused
the
by a valve
intensity,
that is
type,
regurgitated
duration.
or does not close
Does it
tightly.
radiate? Does it
Murmurs
come
are
with or
graded
without
according to their
exertion?
loudness from grade
Any
1 to
associated
grade 6.
symptoms, such as
If you
shortness
hear a
of breath,
high-pitched
sweating,
and the objective
and the
data,
objective data.
the aspects of a
The
patient that
aspects
are measurable
of the
with
patient
examination
that are
and
measurable
tests.
with examination and
These
tests.
include inspection,
These include
looking at the
inspection,
patient,
looking at the
palpation,
patient,
feeling the patient,
palpation,
and
feeling the patient,
auscultation, listening
and
to the patient's heart.
auscultation, listening to the patient's heart.
Subjective data allows you to gather the
Subjective
patient's
data
common
allows
or
you to gather
concerning
the patient's
जी मैम खाना खा लिया मैंने चाय पीता हूँ अभी तो मैं ले आया हूँ सामान
Welcome to this video on cardiovascular assessment. We will be looking at the various aspects of assessment that are necessary to get a good overview of a patient's cardiac condition.
We will be looking at the various
It's important
aspects
to
of
look at the
assessment
subjective
that are
data,
necessary to get
or
a
the
good
patient
overview
point
of
of
a
view,
patient's cardiac
and the objective data,
It's
the
important
aspects
to
of a
look at the
patient that are
subjective data
measurable
for
with
the patient's point of
examination
view.
and tests.
And the objective
These
data.
include
The aspects of a
inspection,
patient
looking
that
at
are
the patient,
measurable with examination
palpation,
and tests.
feeling the patient,
These
and
include
auscultation,
inspection,
listening to the
looking at the
patient's heart.
patient, palpation,
Subjective
feeling
data
the
allows you to
patient,
gather the
and
patient's common or
auscultation,
concerning
listening to
symptoms,
the patient's heart.
including
Subjective
chest
data
pain.
allows you to
Where is
gather
the
the
pain?
patient's
When
common
does
or
it occur?
concerning symptoms,
Describe the
including
intensity, type,
chest
duration.
pain. Where is
Does
the
it
pain?
radiate?
When does it
Does it
occur?
come with or without
Describe the
exertion?
intensity, type,
Any
duration.
associated symptoms,
Does
such
it
as
radiate?
shortness of breath,
Does it come
sweating,
with or without
nausea,
exertion?
palpitations, or
Any
anxiety?
associated symptoms,
Does
such as
anything
shortness of
alleviate
breath,
or aggravate the
sweating,
pain? Does the
nausea,
patient have
palpitations, or
palpitations?
anxiety?
Ask if they have a
Does anything
sensation of
alleviate
racing,
or aggravate the
skipping,
pain?
fluttering,
Does the
pounding,
patient
or
have
stopping of the
palpitations?
heart?
Ask if
Does
they
the
have a
patient have
sensation
shortness
of
of breath
racing,
or
skipping,
dyspnea,
fluttering,
difficulty
pounding,
breathing?
or stopping of the
Does
heart.
it occur with lying
Does the
down
patient
and
have
relieved by
shortness of
sitting
breath
up?
or dyspnea?
Does it
Difficulty
occur when they
breathing?
bend over or when they
Does it
hop?
occur when they bend down or when they
Swelling
hop
or
by sitting
edema?
up?
When is it worse,
Swelling or does it
morning or
occur when they
evening?
bend over or when they
Does it
morning or
improve with
evening? Swelling or edema. When is it worse, morning or evening? Does it improve with elevation? Ask the patient about their history and risk factors, such as personal or family history of heart disease, including hypertension, type 2 diabetes, physical activity, smoking status, diet, and alcohol or drug use. Thrombo
I'm checking around underneath the eyes, looking for signs of xanthelasma that may indicate cholesterol deposits. I'm having a look at the lower, pulling down the lower lids and having a look at the conjunctiva to check for signs of anemia. I'm having a look around the pupil of the eye to look for corneal arcus to check for signs of possible hyperlipidemia. Here I'm looking for a raised pulsation from the internal jugular vein. If that was raised, that would come up from behind the clavicle, up through the sternomastoid muscle, up behind the ear. And next I'm going to have a look at the hair distribution on the lower limbs. Lack of hair distribution on the lower limbs may indicate vascular disease. Also having a look at the condition of the lower limbs to have a look for things like cellulitis or varicose veins or leg ulcers. Hello, my name is Helen Ward and I'm Principal Lecturer at London South Bank University on the Advanced Nurse Practitioner Programmes and Non-Medical Prescribing Programmes. Today I'm going to talk you through physical examination of the cardiovascular system. This will include general inspection of the patient, it will include physical examination of the peripheral vascular system and then physical examination of the cardiac system. My patient has just arrived and I've asked him to get onto the bed for me so I can perform the physical examination. It's very important when you're doing a physical examination of the cardiovascular system to ensure that you've got a private environment and that the room is quite quiet for the patient. It's also important that the patient is lying on the couch in the supine position at an angle of 30 to 45 degrees. Hello Daniel, I'm going to do a physical examination of your cardiovascular system today and I wonder if that's okay with you.
That's fine, thank you.
Okay. Would you mind just removing your top for me please?
Yep.
And I'm going to wash my hands.
Yep.
So, put it on the chair for you. Okay. Alright. Now the first thing I'm going to do is have a look at Daniel's face. I'm going to have a look for any obvious signs of distress. I'm checking around underneath the eyes, looking for signs of xanthelasma that may indicate cholesterol deposits. I'm having a look at the lower, pulling down the lower lids and having a look at the conjunctiva to check for signs of anemia. I'm having a look around the pupil of the eye to look for corneal arcus to check for signs of possible hyperlipidemia. Now I'm going to move on to the mouth. I'm having a look around the lips. I'm checking to see if there's any signs of central cyanosis. I'm looking at the corner of the mouth to check for any cracking that may indicate iron deficiency anemia or vitamin B deficiency. If you could just open your mouth for me please Daniel. Just going to have a look inside Daniel's mouth, looking for the general condition of the oral hygiene to check for signs of that could indicate bacterial endocarditis. And then I'm going to just ask you to stick your tongue out for me please, and I'm just checking the tongue for signs of dehydration. Now I'm going to move on to the hands. If you'd just like to hold your hands out for me Daniel please. First of all I'm going to check for temperature, they're nice and warm. I'm going to check for capillary refill. That's nice and brisk. If you could put your fingers together for me, please, Daniel, like that. I'm looking to check for finger clubbing. You should see a nice diamond shape at the base of the fingernails there. Clubbing will occur in chronic respiratory or cardiac disease. Just like to turn your hands over for me, please. Daniel, I'm having a look now in the creases of the palms to check for any paleness again that may indicate anemia. Now I'm going to move on to the assessment of the peripheral vascular system, but first of all I'm going to measure the JVP. Daniel, if you'd just like to turn your head over to the left for me please. Here I'm looking for a raised pulsation from the internal jugular vein. If that was raised, that would come up from behind the clavicle, up through the sternomastoid muscle, up behind the ear. You need to have a look in a triangle round about this place here. And then you need to have a look for an obvious pulsation within the sternomastoid muscle here. You can see that quite clearly. That will be the carotid pulse. Now I want to have a look, in some people you can see quite clearly distension of the external jugular vein. If the internal jugular vein was raised, or the JVP was raised, it would come up here. Some people measure it, but it's not usually measured anymore. Anything above 2 centimetres is regarded as a raised JVP, and a raised JVP would be visible in patients with right-sided heart failure or portal hypertension. Now we're going to check the pulses. We're going to check the pulses for rate, rhythm and density. First of all, I'm going to check the carotid pulse, one at a time. Okay, once I've checked the carotid pulse, I'm going to listen at the carotid pulses with the bell of the stethoscope for any carotid bruits. Next I'm going to check the radial pulses. And I'm going to check the brachial pulses. Now I'm going to move on to examine the cardiac system. First of all, I'm having a look at the precordium area of the upper body, and I'm having a look to see if there's any old scarring. I'm also having a look to see at eye level to see if there is any lifts or heaves in the precordial area. I'm having a look to see if there's any obvious apical impulse or aortic impulse. After I've had a look, I'm going to palpate the precordium area. I'm going to start by palpating in the mitral area for lifts, heaves and thrills, which may indicate pericarditis, and in the aortic area here. The next thing I need to do is to find the point of maximum impulse, which is the apex beat of the heart that is found at the 5th intercostal space, mid-clavicular line. So I need to count down, 5, and across. So I'm having a feel here at the 5th intercostal space to see if I can feel for the apical impulse. If I can't feel it there, I'm going to ask my patient to roll over onto the left-hand side. Okay, which should bring the apex of the heart closer to the chest wall so that I can feel the apical impulse there, which I can very clearly. That indicates to me that the heart is not enlarged. If you'd like to move back onto your back now. Once I've located the point of maximum impulse, which is just here, I can move on to auscultate the heart for heart sounds. I'm going to be auscultating with the diaphragm of the stethoscope first of all, and then I'm going to be auscultating with the bell of the stethoscope. The diaphragm of the stethoscope will pick up the higher pitched heart sounds, and the bell of the stethoscope will pick up the lower heart sounds. I'm going to start in the aortic area, listening to several cycles of the cardiac cycle as I go down. Now I'm in the pulmonic area. Now I'm listening down the left sternal border to the mitral area, which is between the 4th and the 5th intercostal space. To complete this examination, there are 2 special manoeuvres that we need to perform. First of all, I'm going to ask Daniel to roll onto the left-hand side. And then I'm going to listen with the bell of the stethoscope over the apex of the heart, listening here for any mitral regurgitation or mitral stenosis. Okay, if you'd just like to lie back for me. Okay, now if you could sit up for me, Daniel, please. Okay, and I'd like you to just lean forward slightly for me. Exhale and hold your breath. Now I'm going to listen with the diaphragm of the stethoscope over the mitral area and now along the left sternal border. You need to breathe out again and breathe again and then hold your breath again. And here I'm listening here for aortic regurgitation or aortic stenosis.